Again, let me welcome everyone to our monthly webinar here at the Center for Disaster Medicine at MGB. Today, we are discussing best practices in emergency management to advance health equity during disasters. I would like to thank the Region 1 Disaster Health Response System, as well as the Regional Emerging Special Pathogens Treatment Center for bringing us this course today. Both of those programs are funded by ASPR, which currently stands for the Administration for Strategic Preparedness and Response, and is housed within HHS. We do wish to disclose that the content presented by individual speakers today does not represent or reflect official policy of any position of the US government or the Henry M. Jackson Foundation. None of the content is meant to substitute for professional medical advice or diagnoses either. Information does need to be adapted to each specific patient based on an individual's professional judgment with consideration of the patient's needs, resources available, and other unique circumstances. Neither of our speakers nor I today have any relevant financial interests or relationships to disclose. I am your moderator for the next hour. My name is Dr. Claire Charbonnet, and I am the UMass Fellow in Disaster Medicine and Emergency Operations Management. Our speakers today are Mr. Curtis Brown and Ms. Dr. Shamariel Robertson. Dr. Shamariel Robertson will be going first. She is an expert in public health administration with proven excellence in areas that include public health policy, community health promotion, and emergency preparedness. Dr. Robertson is president of Health and Human Services at Indelible, which is a management consulting firm providing, among many other things, emergency management solutions to both public and private sector organizations. She has previously served as Deputy Secretary for Health in the Florida Department of Health, where she was a key player in the state's Emergency Operations Center during the COVID pandemic. She serves on several boards whose missions include advancing the well-being of vulnerable population. She holds bachelor's degrees in biology and family child science from Florida State University, and she holds a doctorate in public health and epidemiology from Florida Agricultural and Mechanical University. Our second speaker today will be Mr. Curtis Brown. Mr. Brown is co-founder of the Institute for Diversity and Inclusion in Emergency Management, which is a nonprofit organization dedicated to increasing diversity in the field of emergency management and promoting the application of equitable practices to improve disaster outcomes for vulnerable communities. Mr. Brown also serves as the first African-American to become state coordinator of emergency management for the Virginia Division of Emergency Management. He holds a Master's of Public Administration from Virginia Tech and a Master's in Homeland Security and Emergency Preparedness from Virginia Commonwealth University. Before I turn things over to Dr. Robertson, let me finally review some of our learning objectives for today. We hope that we will review the intersection between public health and emergency management and the importance of integrating public health strategy considerations into disaster planning, response, and recovery efforts. We will identify and then describe the disproportionate impacts of disasters on specific vulnerable populations. And finally, we hope that participants will be able to identify at least 2 actions that they can take to integrate best practices to improve equity in their disaster planning and response activities. With that, I will turn things over to Dr. Robertson.
Thank you. Good morning, good afternoon now. I'm Dr. Robertson, and I will be discussing with Curtis Brown how you can best integrate lessons from the field as it relates to public health and as it relates to emergency management. So in this presentation, I'm going to tell you a little bit about my experience. So I was born and raised in a very rural area in northern Florida. With that, I understood very early in life all of the things that come along with health equity. It was an hour for you to make it to healthcare, a hospital, etc. It's a town where they currently don't have a grocery store. So in all of the essence of my well-being, I understood very early what health equity meant, the implications for health equity. I really started my career, with my grandfather being affected by a stroke and it taking like literally an hour and a half to get him to treatment after calling 911. My mom, she was a public health nurse, so I learned about public health early and really focused on dedicating my life to advancing health equity, working for populations that couldn't speak for themselves. Moving forward, I went on to work at the Florida Department of Health at first as a chronic disease epidemiologist, and went on to lead tobacco prevention, public health research, Office of Minority Health, communicable diseases, et cetera, as a Deputy Secretary of Health and during the COVID-19 pandemic. And during that time, I learned a lot of lessons. Prior to COVID-19, I was responsible for health equity initiatives for the Department of Health, and look forward to talking about how to leverage those lessons learned from disasters to advance equity. And now I'll turn it over to my co-presenter, Curtis Brown.
Thank you, Dr. Robertson, and really glad to be here today, and appreciate all the sponsors and for you all to participate to talk about the integration of emergency management and public health with a focus on equity. As my bio mentioned, I have a lot of experience in emergency management, serving as the director and the deputy of emergency management in Virginia, including during COVID-19. I consider myself a practitioner, a practitioner who also does a lot of research. I teach at VCU, University of Southern California, and serve as a senior advisor at the Naval Postgraduate School, teaching emergency management, homeland security, and conducting research at the Research Institute for Social Equity at VCU. And so part of this discussion is integrating some of the lessons learned that me and Dr. Robertson have seen throughout our career. One of the things that we discussed was during COVID-19, it was probably the closest that emergency management and public health had worked together, given the catastrophic nature of COVID-19. And one of the guiding principles, of course, was equity, the disproportionate impact of disasters on historically marginalized and underserved communities. And so part of this discussion, we hope to provide you all with some things that practitioners in government, private sector, nonprofit organization, clearly institutions like hospitals that are community focused need to recognize in terms of better serving those in the community, especially those who are most at risk. Unfortunately, and we'll talk about this during the presentation, this is a consistent failure of ours in emergency management, the disproportionate impact of marginalized and underserved communities. And so if we want to change course, we need to change our practices and embed equity throughout preparedness, mitigation, response, and recovery, especially as we see more frequent and severe disaster impacts. Both Dr. Robertson and myself have been in Florida. Some communities this hurricane season have dealt with 3 repetitive back-to-back hurricanes this year, as well as some last year. And so there's a psychological impact to that as well. So we'll get into this, and hopefully you'll have some tools that can help guide you and empower you, and also to promote the integration of the community in your disaster preparedness, because it's really important to have the community, those who are marginalized, underserved, to be a part of the disaster planning and the response as well.
Thank you, Curtis. And, you know, to the spirit of teaching and giving back post-COVID-19, I was hired by Brown University to create a new course titled Public Health Communications. And that's where I really talk about, you know, how to communicate, you know, prior to, during, after disasters, how to better leverage communication techniques to further advance health equity. So we've talked a little bit about the objectives prior to this, and what we really want to do is talk about, you know, how close the disciplines are, public health and emergency management, and give you practical tools to take with you to really begin to further advance health equity in your health system, in your community. So when you really break down, and a lot of people have talked about the term equity What does it mean? There's been a lot of politicizing around the term equity, health equity, but at its essence, equity is making sure simply that people have what they need to be the best version of themselves, right? So, originally when this term was talked about a few years ago, many organizations, American Public Health Association, CDC, a lot of entities took on health equity, diversity, inclusion as a priority nationally, at states, locally, et cetera. Post, during COVID-19, this became a very politicized term. However, simply put, when thinking about equity and ways that you can advance, is really taking a look at working together in a collaborative fashion to really give people what they need. And whether you use that word or not, simply put, it is just moving health and human services forward to be able to help individuals. And when you think about, equity, it's not giving someone just a one size fits all, is really taking a deep look at, social determinants of health where people work, live, play, partner to ensure that you can give them what they need. And you've seen in the graphics before, some people, when you say increase physical activity, people think automatically give them a bicycle, give them shoes, give them access to a gym, when really what they may need is mental health services to take that next step forward to be able to engage in that physical activity. So it's really taking a step back, looking upstream to make sure that individuals can have an equity lens, that communities can be looked at from an equity lens to take that landscape analysis of the entire community. In this case, looking at health systems, looking at organizations that partner, looking at demographics, who you serve, looking at, cultural competence and sensitivity, making sure that all of those things are encompassed so that you can truly give individuals, communities, health systems what they need to operate at their optimal level. So when we start here thinking about intersection between public health and emergency management, prior to COVID-19, working in public health in Florida, 67 counties, 22 million plus individuals that live in the state, 100 million plus visitors. There are a lot of implications for public health. We've seen Zika, we've seen H1N1, on a regular basis, dengue, a lot of different things, right? Hurricanes, as it relates to emergency response and preparedness. Often during emergencies, people don't think about public health, but there are tons of implications around water. There are tons of injuries. There are tons of suicides post-emergencies. So from a public health standpoint, you're prior to a storm, you're doing health promotion, you're telling people, make sure you have your supply of medications, you're, looking at and working with partners to make sure long-term care facilities, in Florida, there are laws around having generators at long-term care facilities, hospitals for emergency preparedness. You're looking at surveillance, trends, syndromic surveillance in the hospital. If there are increases of certain types of indicators during a storm, you have epidemiologists that are looking for that. You have EPIs that are looking at violence and injury prevention. You have food programs that people don't think about as a normal function of public health, and it is, like the child care food programs that feed over, for example, in Florida, 150,000 children per day in daycares. That's under the jurisdiction of public health. You have public health with the Women, Infant, and Children program doing emergencies when they lose food, being able to quickly make sure that babies can have formula, breastfeeding moms can have the services they need. So when you think about public health, traditionally, we've used data a lot to drive the narrative. And from an equity lens, a lot of the individuals that benefit from public health services, they are most vulnerable. That is what we're talking about here. And most often, you don't engage with emergency management prior to a storm or a disaster, but we are here today to talk about the importance of bringing this together so that we can plan better, so that we can better serve communities as these disasters happen more often. I'll turn it over to Curtis now.
Thanks, Dr. Robertson. And again, emergency management, public health, two different disciplines who, again, have worked together within the incident command structure. But when you look at it through an equity lens, there are definitely some areas of coordination, collaboration. And again, COVID-19 provided that opportunity for us to work more closely as disciplines to leverage our strengths in various areas. I think that emergency management has historically been more infrastructure focused, where public health has been more people focused. And we've learned in emergency management that we can't just be infrastructure focused. We need to be really more people focused and understand the disproportionate impacts of disasters, especially on historically marginalized and underserved communities, and understand why certain individuals and communities, including people with disabilities and low income, low resource communities, are at a disproportionate impacts and more vulnerable. And so we can go to the next slide. We highlight the root causes of disaster vulnerability. And you see this as it relates to environmental injustices, heightening the negative health impacts. A lot of communities that are low income, low resource, communities of color are located in and around toxic chemical plants, for instance. And so when you have a major flood event, those chemicals go into the water supply and can raise and heighten negative health impacts. Discriminatory housing policies such as redlining has congregated communities in and around heightened exposure to natural hazards. This is why the communities are at a greater risk in terms of living in the floodplain. We have a large number of public housing projects in the floodplain. Research suggests that indigenous communities are at higher risk of wildfires as well. And so you look at this, and these are systemic inequities that have started maybe decades ago in the past, but still have present day implications. And they're rooted in racism, sexism, and discriminatory economic policies that really congregate communities and individuals and put them at higher risk. And so we need to identify more equitable practices to make inclusive decisions as it relates to preparing, mitigating, responding, and recovering from disasters. Again, these communities are in areas that we know are at higher risk of disaster impacts. I'll be on a panel next week talking about historically Black colleges and universities. And when you look at where these land grant universities are, they're usually in very high risk areas in the floodplain, on the coastline. And so you go back to when the decision was made related to what land was provided to these institutions. It wasn't the premier land. It was in many cases land that was known to be at risk. And so these institutions are now still dealing with these issues today. And so as we look at building resilience, mitigating the impacts of more severe disaster impacts, we need to be strategic and prioritize these communities and institutions that are on the front line of these climate change impacts, because we know that what we're going to continue to see is more severe and repetitive disasters. And as we focus on resilience and mitigation, we need to make sure that we're not leaving these historically marginalized and underserved communities behind. Next slide. And so definitely, Dr. Robertson, appreciate your perspective on this. But so again, some of the drivers of the vulnerability in the, on historical marginalized and underserved communities, you have social factors, economic factors, environmental factors, infrastructure factors. The infrastructure in these communities are not well maintained and weakened. Going back to redlining, which was an economic policy that existed for most of the 20th century. These communities where individuals were withheld from getting loans, the infrastructure in and around those communities wasn't maintained. And so the sewer system, the the ability to have resilience, the communities that came online last after a disaster, you can clearly identify them based on redlining. We actually did research during COVID-19, and we overlaid our redline communities across the Commonwealth of Virginia with the COVID-19 data related to infections and fatalities, and we saw a direct correlation. And so these impacts still exist today. And so if we're looking at how we can lean forward, we need to look through the lens of research and empowering the community and seeing where do we have these social, economic, environmental factors, and what can we do on our blue sky days to resolve those issues so that when a disaster occurs, we don't see this continued disproportionate impact. Dr. Robertson, would you like to add anything to that?
Sure. So, as an epidemiologist, when you take a look at the data and you use data to drive the narrative, a lot of our existing data sources that provide input about populations, disease trends, they rely heavily on historical things. With disasters, some of these communities are changing faster than the data is allowed to be shared. So for example, when you look at the communities where hurricanes have hit that community back to back, in less than a month's time, in a year, in some of the communities, 3 hurricanes that had never been previously affected before, the data that you're looking at with heart disease, diabetes, hospitalizations that are a year prior to, it's not the same anymore. So the need to have just-in-time data, people to look at it, to look at populations. You see migration of populations during these disasters, people coming in. If you have an area in certain counties that have been affected, sometimes people move in. You have people moving from other parts of the states, other states when disasters occur. That has a huge implication, for example, with school health, looking at vaccine status of children. So there are many things with data that we must identify so that we can better be prepared. And having real-time data and analysis of real-time data to use and for the community to be aware of too, because often public health officials, emergency management, hospital systems, et cetera, other health systems have access to data, but the public and the community don't have access to the data. And if they do, they don't understand the data, how to use it to best, bring and provide, the services that people may need. So there's a concerted effort that's needed to specifically look at data systems around disaster and the emerging of public health to make sure that there are dashboards available, things available during real time, during storms and prior to, so that people have that data available in one place, so that during the disaster, they can react to it, they can see where resources are, they can better inform their planning efforts and their response efforts. Curtis?
Yeah, and Dr. Robinson, to that point, data is one of the key findings as it relates to the history of failure, focusing attention on historically marginalized and underserved communities. One of the things I like to say is the history of disasters, consistently you find that marginalized underserved communities are disproportionately impacted, whether it comes to fatalities, injuries, economic loss, slow recovery or inability to recover. Again, this has been our major issue. And so the research, and here we started in 1957, but based on the research, you can go back all the way to the Great Mississippi Flood of 1927. And you see common themes all the way up to today, the last couple of years, COVID-19, Hurricane Katrina, certain themes, the lack of alert and warning capability to historically marginalized and underserved communities. Dr. Robinson mentioned data, the lack of data to inform response. And so not recognizing that marginalized and underserved communities are being impacted. And so if you're not collecting data and using that to inform response, the negative impacts can increase. And so you take COVID-19 when there was a lack of awareness because of the failure to collect data based on race and ethnicity, that there was a disproportionate impact occurring. And finally, the data caught up to confirm what many in the community saw, was that people of color, frontline workers, et cetera, were dealing with disproportionate impacts. And so throughout these disasters, historically, you see these common themes. The Chicago heat wave of 1995, over 700, mostly elderly African Americans died in that heat wave. And again, it was a lack of resources. It was congregated to the south side of Chicago. And again, a lack of connectivity between the community-based organizations, and resources to resolve these issues. And so in the wildfires of 2018, disproportionately impacting people with disabilities, and a lack of alert and warning capability. And so these are consistent themes and lessons throughout history that shows these failures and disproportionate impacts. And it really highlights the need for us to change the way we approach things, both before, during, and after disasters. The more we can be aware of these issues, the more we can empower and be informed by those who are disproportionately impacted, the better we're going to be on these bad days. But we have to address these issues on the blue sky days. Next slide.
So, creating a culture of equity, of health equity, and how this was really done. So long before, the topic was a topic that people discuss, at first it was, what is equity? What is health equity? And then, my role at the Department of Health was to integrate health equity into the agency strategic plan, looking at those goals, having clear goals around equity, communication of equity, having clear goals around programs to be influenced, like infant mortality, for example, having clear definitions for health equity. Those are the things that, as a department, it was my job to ensure that the different divisions did. And we were intentional about creating a culture of equity by adding those goals into the agency's strategic plan, and putting a concerted effort on training individuals, putting a concerted effort on doing a census to look at health equity knowledge, and putting performance expectations around it, making sure that it was tied to individuals' actual jobs performance. And it was, related to the different types of jobs, had different types of indicators. But in order to really weave the culture of equity, we wanted to make sure we did it in that way. But the ultimate thing was making sure that policy was there. So working to change the policy to add health equity metrics and requirements to the department, and bring in additional personnel, and leveraging additional funding from the federal government and the state to really create a culture of equity, which resulted in a statewide policy to put those liaisons into every county, and then making every county have, plans to impact minority health, et cetera. So likewise, at the same time, I was tasked with leading the priority area work group for health equity for the state health improvement plan. And what that was working across health and human services, hospital systems, tribal communities, universities, community health centers. So working with a host of partners to make sure we could drive health improvement as a state. My job was the chair of the health equity priority area work group. The decision to make that a standalone work group with goals, strategies, and objectives versus having health equity as a thread throughout. At that time, that steering committee that encompassed the state surgeon general, that encompassed the head of hospitals, et cetera, universities, they decided to make it a standalone area that was very intentional about increasing knowledge and awareness about tackling issues like infant mortality, about making sure that data systems were in place as a result of the state health improvement plan. Again, they co-align with some of the agencies' plan to bring that, policy language to the state level so that it could go across the state. We worked to create a health equity dashboard that had multiple data points, health data points, social determinants of health data points. We identified new partners. We were intentional about working with faith-based organizations. One of the lessons that I've learned in life around health equity, one of the most important partners is faith-based organizations when really deploying a culture of equity, making sure that you're doing nothing for a population without a population. Oftentimes in the equity discussions, people talk about how to achieve equity, but they often leave out the people. Nothing for people without people. So being intentional about making sure that the populations you're serving, that they're at the table. And not only are they at the table, oftentimes people do focus groups, key informant interviews, but when it's time to implement, they don't implement the changes that the population told them they wanted to see. So data is one thing, but engaging that population to ensure that they're encompassed, working with non-traditional groups like community health workers, which is an evidence-based model with really driving those community clinical linkages is one of the most evidence-based things in public health that they've put out, making sure that you are working with members from that community, but they're trained to make sure that that community engagement is there, is a lesson learned. And I think during emergency and disasters, that is one thing that I have not seen yet, with community health workers being specifically trained to respond, to prepare, and to help individuals. They are the individuals that understand the resources. They do a lot with closed loop referrals to make sure that those non-medical drivers are met. They are a critical part of the care coordination teams, or should be a critical part, but being intentional about how those community clinical linkers can really help really advance health equity is a conversation that some people have begun to have, but it's something that should be explored. So when you look upstream and you're thinking about it, before somebody is in a crisis, before that emergency response, before there's a shortage of a medication, et cetera, there should be a look on when the skies are blue. What should you be looking at? Education is a predictor. So when you see communities and they have lower educational attainments, those are communities that need additional supports. When you see that heart disease in some areas, stroke, et cetera, they've had poor outcomes for 20, 30 years. Those are populations, communities that should be addressed and targeted for interventions prior to emergency. And it's not just on the health system end, but it's just looking and working with those community-based organizations that people work with often to say, prior to a disaster, these are the things that you need to consider. Do you have a way to take your medication? Are you aware that you can get that 90-day supply, prior to? Do you have a plan in place if you have a CPAP machine, if you have oxygen? Like, those are all of those upstream things that people don't often take into consideration with case management, with individuals, with communities. When you're looking at long-term care facilities, for example, making sure that, and I've seen this in a couple of disasters and seen it recently, often with long-term care facilities, sometimes they have to evacuate the entire facility during a disaster. And family members, they don't have sometimes good communication channels. The individuals that involve, oftentimes they can become very confused. So having all of these conversations to understand that, because from a hospital systems standpoint, you could completely have an entire long-term care facility that is evacuated during a storm. And I've seen that before, where you get over 100 individuals that are aging from a completely different county. Now they could bring an influx into a hospital system, and that planning assumption that hospital system may not have accounted for. So these are the types of conversations and considerations that should happen upstream. And, when you're in the actual event, if you have prepared, you're better aligned to respond. Looking at strategic stockpiles. So for example, during COVID, when there were shortages in ventilators, et cetera, some of the offices that did standalone elective surgeries were leveraged when looking at different medical groups. They had groups for example, Black doctors, Black nurses, NAACP, Urban League. All of these groups were very critical and important. Historically, Black colleges and universities were leveraged, and we'll show you a case later where they can really talk about a lot of HBCUs and minority serving institutions are not our one group. So really figuring out, having that conversation on how to leverage those organizations, those universities, to really be a part of improving health outcomes from an equity lens is important. Multi-sector partnerships. So, in the political climate, we see a lot of things that may not align, from state to the federal government, et cetera. But it is important to understand the major players, and people often say partnership, but they don't actually take the time to truly map and engage those partners. So though there are federal partners, there are federal community-based organizations, 501c3s, that should be leveraged. They have a good pulse on the population. Local community-based organizations, when you talk about health systems, one of the exercises I did at the Department of Health was I was a principal investigator of a grant, 1305, which was a grant to look at collaboration across health systems. And the biggest thing that multiple states talked about was even defining what a health system was and how many health systems were in the state. So, people counted it different ways, some hospital systems that had multiple, placements in different counties, rural health centers. You had health departments, you have different types of health departments, county, state, local. So when you look at this, universities, business, those for-profit, nonprofit relationships, all of these different players can really help you get to an equity lens. You have businesses that give money to nonprofits that can help advance equity. You have the federal government that's giving grants to different groups. And one of the things that's truly important that people don't understand is making sure that there's a clear path to communication. So making sure that you have those scripts available. What will you say if during an emergency you have this? So we've looked, for example, with Ebola, in the actual health departments, they're doing these exercises in the hospitals that have the contracts. If you transport a patient, yes, they know, but smaller rural hospitals probably have no idea of what to do if this happens. And there are some exercises, but the public is not even aware of if this happens, what does this mean? So really working with those mass media channels, really having a strategy and a communications plan in place on how you would communicate, and then telling people prior to the disaster, because once a disaster hit and you're in that moment telling people how they're going to receive communication, you're already behind. So making it clear to people that are in a health system, this is how you would receive a communication if there is a disaster, is super important. And then schools, and that's from universities down to early childhood education centers, down to, K through 12 schools, because often during disasters, schools are disrupted. During different disasters that's related to communicable diseases, schools are affected, like measles, etc. So having those open relationships between emergency management, public health, and having a coordinated way to communicate is important. One example that I'll give you is with communicating with health systems during COVID. There were routine calls with hospitals, routine calls with nursing homes, routine calls with different types of health systems, so that we could give the information that was important to them. But, post COVID, I don't hear people having those conversations anymore. And a lot of the people who responded during that time, they're not there. A lot of people retired. A lot of people were expected to retire even before COVID-19. So we're really, not taking the lessons learned even a couple of years post COVID-19 to really, go back and learn from those lessons, create that culture of equity. So it is super important that we start to have these strategic plans. We write these things down, we train on them. They are systemic. We educate on them in schools, because we didn't receive this kind of training in public health school to be able to respond to an emergency. We did it in practice when it was time. We made some mistakes. We had lessons learned. But now post that, the reason we're having this conversation, we need to memorialize it. We need to write it down. We need to train on it. We need to be intentional. And after every disaster, we need to have those after action reports and really write down those lessons learned. One of the things right now with Hurricane Milton and Helene, and coming off post Debbie, like some people never contemplated multiple disasters in an area at one time, which is something, to Curtis's credit, he said could happen prior to this happening, and the need to plan for that. It is a very different plan when you're responding to multiple disasters on top of each other at one time, and those planning assumptions have significantly changed. So before disasters, Curtis will talk to us a little bit about that.
I think that Dr. Robertson, and just want to give some nuggets on the inequities that exist before, during, and after disasters. And I know we're going to try to leave some time for questions here at the end. But before disasters, you can identify the inequities based on looking at where our resources allocated and where they're not, and where they're not usually allocated in terms of funding to build resilience, to improve the infrastructure, to educate the public about disasters, are in historically marginalized and underserved communities. Likewise, the lack of access to information, even from a language access standpoint. Is the information translated into different languages? Is it accessible to people with disabilities? Usually you see a failure to do that. Infrastructure and housing. Are we looking at where the substandard housing is that cannot be resilient against major disaster impacts and are at higher risk? And again, the history and the systemic legacy of inequities, whether social or economic, environmental, that congregate individuals who are historically marginalized, underserved, in highly disaster-prone areas. And as I mentioned earlier, what data are we collecting? As Dr. Robertson said, are we investing in research on historically marginalized, underserved communities? Do we have the data to inform the actions that we would take? In many cases, we have not done that. And so we are essentially not empowered to make data-driven decisions, because we've not empowered the communities and we've not invested in creating the dashboards and collecting the data to inform our actions. Next slide.
So this is just a case study to show during COVID-19, FAMU, which is an HBCU, they stepped up, allowed the state to use the property to do testing, to do vaccines, et cetera. It became the most used site amongst minorities. And, it was a site where they engaged and worked together with this university to bring different research initiatives, but it was a pillar to the response locally in the northern region of Florida.
And then after disasters, you see historically, again, this is based on the research, the speed of recovery is slower in historically marginalized, underserved communities. There's actually an example from the Northeast, from a hurricane in the last century, where the power company did not go to the community of color because they were not comfortable going there. And so they reconnected the power in other communities that were less impacted, while the majority of those impacted were delayed in terms of recovery because they didn't have the cultural competence or the connections in that community to be comfortable going there. And so these examples delay the negative impacts, or extend the negative impacts on historically marginalized and underserved communities. You also see displacement, individuals having to move well away from where they're from. You definitely start to see the mental health impacts. And of course, we've seen that in Florida with the back-to-back impacts of disasters, just mentally draining. And we really need to focus on mental health on survivors. And policies and planning, the policies for getting folks back on their feet. We right now have a really complex recovery system that leaves a lot of folks behind. The data indicates that communities of color lose on essence of $100,000 or more, while wealthier communities gain funding and resources. And that's because the ability to navigate this complex recovery system we need to really integrate equity and to make the disaster recovery process more equitable and easier for communities of color, low-income communities, and people with disabilities. Next slide.
So this is an example post-COVID-19 where housing funding, we work to do community outreach to provide assistance with mortgages, back taxes. This was funded out of U.S. Department of Treasury, and it was a resource to help under-resourced communities get back on their feet post-disasters. So really educating those communities on different resources available from state, local, federal organizations are very important to ensure that we create a culture of equity. The next case study is really looking at crisis counseling, which is funded, by SAMHSA. And crisis counseling is, having these individuals that are trained in behavioral health. They often engage in canvassing. They help people understand during this time of crisis how to navigate resources. I'm directly working right now to oversee some crisis counseling work in the state of Florida. They are in the different areas that are affected by Helene and Milton, and just really taking in some of the things that people need. And if they come in and they're struggling to even talk and process and they're still in shock, they can't leverage the resources. So having behavioral health individuals on ground is very important, and not just any behavioral health person, but making sure that they're actually trained in crisis counseling is very important so that they can help them navigate the nuances of a disaster. This is just something people should be aware of, and working with local organizations to understand how you would deploy crisis counselors during a disaster. The path forward, we'll let Curtis start it.
And these are, again, just some recommendations for how do we address this legacy of inequities and disproportionate impacts as it informs your work wherever you are in your organization and as an organization as a whole. We can all be advocates for equity and leverage these tools to reverse this trend. And so how do we do this? Leveraging data systems to capture public health and emergency management real-time metrics, be informed by equity-related data. So we're looking for those historically marginalized and underserved communities. Cross-sector collaboration, going outside of our normal partners. And as Dr. Robertson mentioned, our nonprofits, community-based organizations, faith-based organizations, partnering with them, because in many cases, they understand the community a lot better than we do. Collaborative pre-planning ahead of time, and not just waiting until the day of the event, and we're already behind at that point. And I'll let Dr. Robertson close out, and then we'll take some questions.
Yeah, and leveraging individuals from the community, making sure you're engaged prior to with the thoughts, and understanding cultural competency, and just being sensitive about it, and making sure that's a part of the response and part of the planning through the use of individuals such as community health workers is very important. And we will take questions. Thank you.
Thank you so much to both of you, Mr. Curtis and Dr. Robertson, especially since I know you're both working hard to respond to disasters in your respective communities, but like immediately right now. I want to thank our attendees for participating in today's webinar. I have a couple questions to kick us off. I love the expression, nothing for people without people. I think that was beautiful. And we fail to advocate for people for step one if we don't engage with those communities we're trying to serve. And I've seen retrospective data that shows vulnerable populations can be harder to reach with respect to like pre-disaster planning and response. So I'll ask both of you, what outreach strategies have you found most effective in communicating with some of these vulnerable populations we hope to reach?
Good question. So as a person with lived experience coming from a community that is hard to reach, under-resourced, et cetera, I think one of the things to do is really you have to find trusted members of that community, have those conversations, even educate, on different things that you're trying to do, because with under-resourced communities, they often want the help. So engaging those trusted leaders first, and then helping to come together with the trusted leaders to have a concerted message. This is what we're trying to do. Can you assist us? And, actually hiring them. So when you have budgets, when you have grants, when there are disasters, a lot of frontline workers and people in these under-resourced communities, they're without jobs because when you don't have power. If they work at restaurants, they work at different places, they're out of work. But actually coming together prior to pre-rostering those individuals to say, if there's a hurricane, you can join us on the ground. Canvassing is a very important tool for engaging this. It's grassroots, on the ground, walking the pavement, speaking to people, being personable with those trusted members is a good way to engage that community. A lot of times you're not going to get them on social media, for example. You're not going to get them on mainstream communications and run a campaign. That is a strategy, not to negate that strategy. But during disasters, people want to hear from people. They want to talk to people that look like them, that understand where they're coming from, that understand, that prior to the storm, they had leaks in their house, that understand the nuances of rural communities, other communities, that understand that they may not have had the money to evacuate, and we understand why you stayed. We're here for you. So having that real person in time on the ground, not having people always come to you for a central part of getting resources, but bringing resources to where people are. That is important for engaging, what people call hard to reach communities or marginalized, under-resourced communities.
Thank you. That makes a great deal of sense. If someone here in attendance is like a municipal public health leader or hospital administrator who's feeling overwhelmed at some point in the disaster life cycle, can you help us understand what partners exist at the state or federal level to help with planning, particularly with respect to vulnerable populations?
So good question. Being a public health leader myself before, of course, there is a emergency support function as a part of the incident command structure that deal with health and human services related type things. But, if you're feeling overwhelmed, for example, you have different organizations that assist during disasters. So you have National Association of Chronic Disease Directors, you have the Association for State and Health Officials that'll give you a lot of that support. So during COVID-19, they just had a call for health officials to get on and air out their frustrations, get help from other states. And, with all of the policy things that are taking place, some of the traditional lines that you had with project officers between the federal and the state level that may not exist in some cases. So, I would even argue for prior to a disaster, like having those safety nets in place. If you understand that that relationship is such with the federal government and you're at a state and it's not the same as it was 10 years ago, reaching out to those national nonprofit organizations that are there to support states. Epidemiologists, you need to have that established relationship, be there, having those set up points of communication with health systems prior to an emergency. If we have an emergency, this will be our routine call. This is how we would communicate. And, during a disaster, people think things don't always work. So if you are a health leader, so what I'm saying is broadband issues have become a problem in these areas. So you thinking you're going to get on a call and you're going to have this nice conference call, that may not be the case. So you have to make plans on top of the plan. So for example, if you can't have that nice Teams call, you can't have those other calls. As soon as the way is clear, you're going to have to work to make sure that you have alternate forms of communication, that people are able to go in and out of that area when it's humanly possible. To communicate is real important, and it may be needed. Having traditional radios, for example, I'm talking AM, FM, that might be a way that you have to get messages in. So having those things available, that's something you can do. But the most important thing is having a plan. There are very few states, municipalities that have a public health emergency preparedness strategic plan that's exercised and reviewed on a regular basis. But I think that's your first step in getting there prior to a disaster.
Thank you so much. I have a question here from one of our attendees. asking, have you considered the Medical Reserve Corps to help canvass and identify populations that need education on disaster preparedness, and to share what resources are available to them during a disaster? She then details at length about some of the work that the Medical Reserve Corps has done here in Massachusetts, including volunteers supporting disaster and recovery, staffing shelters, different cultural competency representation, et cetera.
Excellent resource, and they are used in Florida and other states. And, you know, I've had the privilege to actually work alongside the reserve, you know, when we once had to evacuate a long-term care facility from a county during a hurricane, and they came in and they were absolutely amazing with bringing nurses who were prepared to work with individuals from that long-term care facility to bring in respite support when local workers had been there 24 hours. And I can't say enough, but that's definitely a tool that should be shared with all states, and having those service agreements in place prior to storms and leveraging that reserve is important, because local health officials get tired. Local medical physicians, sometimes they're overworked and have to work long hours in their hospitals, clinics, etc. And when those base camps or those shelters are remaining for weeks on end, it's important to engage that reserve along with other vendors and contractors to make sure that you just have the appropriate amount of help needed during a disaster. Good resource.
And I would just add that is a great resource. We use it in Virginia as well. But as Dr. Robertson mentioned, the community health workers, hiring individuals from the community to do the door-to-door canvassing, we found that is really effective to close our vaccination gap and to promote, to address vaccine hesitancy. So we were economically investing in the community, individuals who had possibly lost their jobs, but understood the community best. And so as we look to build the public health and emergency management workforce and diversify it, because there's a big issue of diversity as well, we can do that intentionally by building this bridge of taking these individuals who understand their community the best. I always say emergency management is not rocket science. We can teach and train emergency management. What we lack is that knowledge and understanding of the community and the cultural competence. And so I had a conversation one time with a major national nonprofit, and they were saying we can't get enough volunteers from this community of color that was low income, low resource, and volunteering is a privilege, and so sometimes you have to pay folks for their knowledge, and you can address economic issues and leverage that knowledge. And so I really want us to really focus on building this next cadre of public health emergency management leaders from these communities that are historically marginalized and underserved.
Thank you so much. That's all we have. I know we're at time, Claire.
Yes, absolutely. Thank you so much to both of you. I appreciate your being here. And again, and thank you to Mass General Brigham Center for Disaster Medicine for hosting us. Thank you to all of our attendees for joining us. This was wonderful.